Hi, I'm Jamie Capel. I'm a neurology attending, and I'm going to be speaking today on neuromuscular conditions that you may see on the boards. First, we'll talk about Duchenne and Becker muscular dystrophies. So these are caused by a defective gene located on the X chromosome. It's responsible for the gene dystrophin. The prevalence is about, 1 to 2 per 10,000 live male births. Weakness usually begins around age 2 to 3 years. You'll mostly see proximal muscle weakness in the lower extremities greater than the upper extremities. This can be seen where the child has difficulty running and jumping and using steps. When arising from the floor, many of the boys will kind of use their hands to push themselves off the floor, and that's called a Gower sign. You may also notice lumbar lordosis, so they kind of walk with their belly stuck out. That's due to hip girdle weakness. So it looks kind of like a waddling gait, and you'll also notice some calf hypertrophy. These boys often have slowed growth velocity, not just due to their disease, but also due to the treatment, and they're typically wheelchair bound by adolescents in Duchenne. So things to think about are if you were to sometimes some of the first things you can check is just a creatine kinase, which is usually 20 to 30 times normal. Associated conditions to keep in mind are a primary dilated cardiomyopathy and conduction abnormalities. They can have progressive scoliosis. They can get frequent fractures due to the glucocorticoid treatment that they get for their Duchenne or Becker. They can also have some cognitive and behavioral difficulties. The diagnosis nowadays is via genetic testing. So, in thinking about management of Duchenne and Becker, we use glucocorticoids most often, and this improves motor function and pulmonary function, delay loss of ambulation, and improve in survival. Physical therapy and low impact exercise. It's usually multidisciplinary management, and the prognosis. So for Duchenne, just to sort of review, Duchenne is typically they lose their ambulation during adolescence. They can live into early adulthood. Now with new treatments, they are living longer. Becker is a much milder version, and they may not lose ambulation until adulthood, and many of them are living into their mid-40s, and so their weakness is much less. So next we'll talk about spinal muscular atrophy. And this is degeneration of the anterior horn cells in the spinal cord and the motor nuclei in the lower brainstem. This results in progressive muscle weakness and atrophy. The incidence is about 4 to 10 per 100,000 live births, and there are multiple types, so SMA 0 all the way to SMA 4. This is an autosomal recessive condition. It is actually caused by deletions or a mutation in the SMN1 gene, so that results in deficiency in the SMN1 protein. This gene is located on chromosome 5. Exon 7 deletion is the most common deletion that we see, and the phenotypic expression of SMA is related to the amount of the SMN2 protein that's expressed. So the more SMN2 protein you have, the milder your disease is. So let's walk through this table here. So we have the most severe onset is SMA 0, which is usually prenatally. They are really not even able to achieve a sitting position, and their life expectancy is less than 6 months, and they only have one SMN copy number. And so as you go down, the more SMN copy numbers you have, the milder the disease presentation. SMN1 is a common one that we see where their presentations during infancy, and they usually don't live past 2, and then as you get older, SMN2 is SMA2 is you're able to sit. SMA3 you're able to stand and walk maybe with assistance, and then SMA4 is the mildest, where you have greater than 4 SMN2 copy numbers. So in thinking about the clinical presentation, you're going to have proximal muscle weakness in the lower extremities greater than the upper extremities. You'll have absent deep tendon reflexes, which is a common way that we actually find out that there's a problem. In the more severe forms, you'll have restrictive and progressive respiratory insufficiency. The weakness usually spares the face and eye muscles, but you will see tongue atrophy and tongue fasciculations, which also gives you a clue. You should suspect in any infant with unexplained weakness or hypotonia, and then the diagnosis is through genetic testing. So next we'll talk about myasthenia gravis. This is the most common disorder of neuromuscular transmission. The prevalence is rare, so 70 to 320 per million, is caused by antibodies to the acetylcholine receptor, most commonly, but it's also caused by antibodies to the muscle-specific receptor tyrosine kinase, and this is in the neuromuscular junction. So the hallmark of this disorder is fluctuating degree and variable combination of weakness in your ocular, bulbar, limb, and respiratory muscles. Usually occurs most often in females during the 2nd to 3rd decade. You could have two forms, so generalized myasthenia or just ocular myasthenia. And 10 to 15% have an underlying thymoma, so that's something you definitely have to think about when you're working up these patients. So the clinical features are fluctuating skeletal muscle weakness and fatigue, so it's typically worse at the end of the day or after a lot of exercise. So like I said, proximal muscles are affected more often. You can get ptosis or diplopia, which is the presenting sign in about half of these patients. They also can have dysarthria or dysphagia or fatigable chewing. You can have respiratory muscle weakness, and that's typically associated with a myasthenic crisis, and that requires hospitalization. You diagnose it by clinical history. You can do a blood test for the antibodies. You can also do repetitive nerve stimulation. Next, we talk about congenital motor sensory neuropathies. Charcot-Marie-Tooth is probably one of the most common ones. This is caused by mutations in many different genes, but the products are expressed in myelin or the axon structures of peripheral nerves. The Charcot-Marie-Tooth disease type 1A is the most common, and this is caused by duplication in PNP22. It is autosomal dominant, usually presents in the 1st to 2nd decade. You'll see distal lower extremity weakness and atrophy. These patients usually don't have reflexes, and they usually have pes cavus, which is a very high arched foot. They can have sensory loss, so loss of proprioception and vibration. Guillain-Barré syndrome is something that you'll definitely encounter on your boards. It is otherwise known as acute inflammatory demyelinating polyradiculopathy, and it can also be axonal. It's usually an acute monophasic illness, most common cause of acute flaccid paralysis in infants and children. There's a precipitating infection in about 2/3. Campylobacter is usually a cause of the axonal version of Guillain-Barré. These patients will develop symptoms over 2 to 4 weeks. Clinically, they'll have ascending symmetric lower extremity weakness. They may have back pain or leg pain. Their gait will be abnormal, and they usually will not have reflexes. Symptoms can progress in hours to days. It can involve the arms, the respiratory muscles. They can have autonomic dysfunction in about half. There are several variants. The Miller-Fisher variant mostly affects your eyes. They also can have ataxia and muscle weakness with areflexia. So to work up Guillain-Barré, you'll do a lumbar puncture, which will show elevated protein in the setting of a normal white blood cell count. If you were to do an EMG or nerve conduction study, you would notice conduction block or slowed nerve conduction velocities. A spine MRI is pretty nonspecific. It may show enhanced spinal nerve roots, but it's not often used for diagnosis. So the order of the testing that you would look at is functional vital capacity. So one of the most common things that we need to think about is this, quickly escalating respiratory insufficiency. So you'll want to look at that, and then a lumbar puncture, and then admit. So treatment, low threshold for intensive care management, IVIG and plasmapheresis are often used for treatment. Prognosis, most people do well. The severity of your illness doesn't correlate with outcome. Kids usually do very well. Transverse myelitis is Spinal cord dysfunction, it can be acute or subacute. It's usually post-infectious. It's usually autoimmune. You can have also some rapidly progressive weakness. And in transverse myelitis, you'll always have a sensory level, so look for that in a question. You'll also have bowel and bladder dysfunction, which those are two things you do not see in Guillain-Barré. For this, spine MRI with contrast is actually very helpful. You'll see an enhancing abnormality of multiple segments of the spinal cord. The CSF is abnormal at about half. You may see lymphocytosis and an elevated protein. Treatment is steroids, and most patients have partial recovery, but the recovery is not usually not as good as Guillain-Barré. And this is just a table to think about how you would work up acute myelopathy.